4-year-old with the no exanthema or no similar history of other cases in the family. But he has pain and difficulty in swallowing even with the liquids. So you now know the difference between the previous case and this case. You can see the throat. There are various marks I have put. One is there is a patch on the tonsil. The uvula is congested and red, beefy red, what you call. The upper fauces is congested, and the tongue is more of a gray or furry tongue. And so looking at the throat, just a simple clinical examination, you can easily diagnose or differentiate between the viral and bacterial. So if it is a bacterial, you have a swollen uvula, you have a red swollen tonsil, white spot on the tonsil, red swollen throat, and gray or furry tongue. Whereas even in a viral, you can see red swollen tonsil, but there is no patch. Throat can be congested. So this is a simple method to differentiate. Then do you have a criteria to suspect group A beta hemolytic streptococcal pharyngitis? Yes, there are various clinical criteria which are very simple to practice. Even it doesn't take 1 minute if you are an experienced pediatrician. And tonsillar exudate, tender anterior lymphadenopathy, fever, and absence of cough. These are the 4 things you have to look for. One is fever, absence of cough, anterior lymphadenopathy, cervical lymphadenopathy, and tonsillar exudate. And those with less than 3 points are unlikely to have group A streptococcal pharyngitis. So now let me compare these 2 cases, and when you compare, you will get the answer. The first one had acute onset with red eyes and some kind of cough. Pharyngeal congestion was there, but there are no cervical lymphadenopathy or exudates. And age is another thing. The bacterial pharyngitis or sore throat is very uncommon in a child less than 3 years. So most probably the first one is a viral, and second one, if you compare the acute onset, a severe throat pain, rapid progression, follicles, lymph nodes, toxicity, age of more than 3 years, this is more of a bacterial infection. So now you know how clinically or in the busy practice you can differentiate between a viral and a bacterial. Do I investigate or do I start an antibiotic? So investigations are not required. ASLO is not required. But the only thing is most of them are clinical diagnosis. No routine investigation. Only thing is when you are in doubt, you can use the take the help of RAD, that is rapid antigen detection test. So let me tell you what is the utility of this RAD. It is more specific of about 95% and sensitivity is 70 to 90%. It is cost effective. And there was a paper in the National Medical Journal by Dr. Balasubramaniam. He has done a study on the utility of this thing, and he found, and he now also he does routinely this particular test in his practice. So it is a very simple procedure wherein streptococcal, the 2 marks are there, the control, and if it is positive, you get the second line when you put the sample in the sample well. This is very simple. Within 5 minutes, you can tell that though the availability is less, but when we start doing it more, probably the availability will be more, and it is a cost effective in the sense it is not more than 200 rupees per test. So it is such cheap, but we are not utilizing it more. So it is an excellent point of care test, and turnaround time is around 5 minutes only, sensitivity of 96% and cost effective, and this should be propagated as a part of antibiotic stewardship, avoid antibiotic abuse. So this particular child, should I treat? Yes, here you should give antibiotic. The first case, you should not give antibiotic, and in the second case, you should give antibiotic. Why antibiotic? Why? Because one is it will prevent the complications. The suppurative complications can occur, recovery can, and spread to one can occur, and non-suppurative complications like rheumatic fever also can be prevented, and especially when it is given up to 9 days, which I told. So which antibiotic? Though we say textbook, if you say penicillin is the first choice, penicillin is not available. So amoxicillin, 50 milligram per kg twice daily for at least 10 days. And mind you, the duration is very important. Most often we need to advise the patient that it should be taken for a proper duration. Generally, they after 3-4 days, when the child becomes okay, they tend to stop, and then again recurrence and other complications I have seen a lot. And this is a chart which can be seen in any other standard textbooks. So management protocol, examine the eye, ear, nose, and conjunctivitis, coryza, hoarseness is there. Viral, you give symptomatic response. Whereas purulent patches, toxic lymph nodes, and it is bacterial. Antibiotic, either you do the RADT or culture, and if the culture is positive, I mean the culture or RADT is positive, you give antibiotics. So, in summary of this particular cases are that you should suspect bacterial tonsillitis in a older child. Rapid antigen test is a very good test, and there is no hurry to start antibiotic. Even you can wait up to 9 days. By that time, most of the viral will subside. Amoxicillin is the first choice, and treatment duration has to be 10 days.